It's a privilege to give this talk in Dr. Johri's presence. He's my mentor. So there's a saying that the eyes cannot see what the mind does not think of. So this is a child actually who presented to us with quadriparesis and had actually underwent orthopedic surgery for the forearm by, for a correction. And it was not actually diagnosed that the child had a atlantoaxial dislocation. So all spinal deformities may not, be very obvious and need to be looked at, especially the children who have skeletal dysplasias and syndromes. We need to, check them. Spinal deformity surgery is not only about correction. So there is a definite role of conservative treatment and bracing in a majority of the patients. So the approach to a spinal deformity really is a good history and a clinical evaluation, identifying the etiology, evaluating the x-rays and other investigations, the age of the child and progression, of the deformity. One needs to look at that, evaluating the treatment options, and then follow up, with whatever option you choose. So on history and clinical evaluation, what are the important things you'd look at? So this child actually, looks fairly straight, if you look at just the coronal view. But when you ask the child to bend forward, you will see that the rib hump is pretty obvious. It can be measured with a scoliometer. One needs to look at the shoulder levels. And with a significant rib hump like that, one has to understand that there's going to be a double curve. You need to look at the flanks, if there's asymmetry of the flanks, the position of the pelvis, whether the pelvis is level, the range of motion, the skin. So this child actually had cafe au lait spots, and of course the neurology, if the child is having any upper motor neuron signs. So actually this is the curve of that child, so it doesn't really look very obvious when you see the patient, but this was a neurofibromatosis curve. So evaluating the patient is very, very important, before one thinks of managing. So what about the etiology? How do you classify the etiologies? So there will of course be some telltale signs like, the skin in neurofibromatosis, if there's an obvious history. Often you have to look at the curves. So actually the idiopathic curves are the diagnosis on exclusion, when there is no definite congenital cause seen, like an hemivertebra in the second picture there, or a syndrome which you have to rule out with bullet-shaped vertebrae, or the scalloping which is seen in neurofibromatosis. So these are all the radiological signs which give us a clue. How do you evaluate? So it's classically the Cobb method, to evaluate X-rays. Usually you advise standing X-rays for all these children with deformities, and you measure the Cobb angle, which is measured from the end vertebrae. The end vertebra is the most tilted vertebrae, and one needs to draw that angle. There is a measurement error of 5 degrees. So you don't call it as a progressive curve unless there's more than 10 degrees on subsequent follow-up. Looking at the vertebral rotation. So this is a Nash and Moore method where you look at the vertebral rotation and you classify it, depending on how rotated it is. So this is a picture showing you the end vertebrae, which are the most tilted vertebrae. It's important to differentiate the neutral vertebra and the stable vertebra. The stable vertebra is the vertebra which is actually bisected by the central sacral vertical line, and the neutral vertebra is the vertebra which is actually not rotated, so neutral, okay, which means not rotated, as in difference from the end which is the most tilted. So one needs to also look at the sagittal balance. You can't just treat patients on the AP X-ray. You have to have a lateral standing X-ray, and you see where the C7 plumb line, goes. It usually should bisect the L5S1 junction. This is the Lenke classification, which is commonly used for all idiopathic scoliosis. I'm not going to go into it. It's out of the purview of this talk. But basically, there are 6 types. And so is this an idiopathic curve? And probably a majority of people will think it is, but it actually is not. This is an MRI showing a syrinx. So one has to have a good clinical examination, look for abdominal reflex asymmetry, look for any, wasting of one of the legs, sometimes, just hyperreflexia, but keep a very high index of suspicion. It's important to have an MRI done for all congenital curves, for all juvenile curves, and any atypical idiopathic curves. okay, because one can land up in a soup if you go ahead and offer treatment, without checking these things. So progression. So Dr. Aru just gave an excellent talk on how to assess, the growth in children. So what we use is the RISA grades, okay, and the reason this is very important is that if you notice, a child with a RISA 0 or RISA 1, who has a curve between 20 to 29 degrees is almost at a 70%, has a 70% chance of progression of the curve, versus a patient who's coming, a little later, with a RISA 2, 3 or 4, where the chance of progression is less than 20%, for a larger curve. So very important when you prognosticate and discuss with the family and discuss the various treatment options. And actually it is this grade, the RISA 1 and 0 who are helped with other forms of treatment like bracing or, casting if needed. So this is again looking at the peak height velocity, and there are problems of early surgery like, crankshaft. So that's why one of the reasons we try to delay surgery as much as possible in children. In congenital scoliosis, one needs to be very wary of two types of curves. One is the curve where there is an unsegmented bar with a hemivertebra on the contralateral side, because these are the highest risk of progression and they will benefit with early surgery. The other group is the hemivertebrae, where there is a likelihood of progression. So what about the natural history? The study by Weinstein, for idiopathic scoliosis patients, where they actually followed 100 patients for 40 years and found that curves which were below 30 degrees did not tend to progress, versus curves which are more than 50 degrees, which almost always tended to progress, by 1 degree a year. And lumbar curves, the threshold is lower, it's 30 degrees, so curves which are more than 30 degrees will progress. Now looking at treatment. So usually the rule of the thumb for idiopathic curves is if the curve angle is less than 20 degrees, you'll observe. If it's between 20 to 40 degrees and the RISA is less than 2, you'll brace. And if it's more than 50 degrees, you'll consider surgery. This is a child who presented at the age of 8 years, and she was treated with a brace. And this is a follow-up. So bracing has a very, very important role, provided you pick up the patients right in time, okay? There is a landmark study, a prospective study on bracing by Weinstein, and where they actually had a multi-center study of 240 patients from various centers, and they actually stopped this study somewhere down the middle because they found that bracing was, the bracing patients did so much better than the patients who were observed. So actually ethically they had to close the study and publish the results. So there is definitely a role for bracing at the right time. So this is a girl, who I've been seeing. She's a 12-year-old girl, and she actually is being treated in a brace. Again, very subtle curve, you can easily not pick it up. And nowadays there are newer modalities for bracing. There is this CAD-CAM methods where they actually look at each vertebra, and then the brace is made considering all these parameters. You actually look at the vertebral rotation and the vertebral axis of each segment, and for an optimal brace. So coming to the surgical part, all right, so to simplify this, there are two types of coronal decompensation. The first type is basically where the shoulder is elevated and the apex of the deformity is on the same side. And this is an example of a patient like that, okay, where the shoulder is elevated on the same side, there is the thoracic apex, and this is a straightforward patient to treat because you just have to deal with the convex sided curve and you reduce it. You will have a reasonably good outcome. It is the second category actually which is the difficult one, and you have to pick it up, because if this patient, if you kind of don't pick up the fact that there is a problem at the lower part of the pelvis, so the LS junction, so if you see the L5 vertebra, it is basically structurally deficient on one side, and in this patient if you actually look at the obvious curve and you just correct that right-sided thoracic curve, you will push the patient off to the side. And here we actually went down to the pelvis for correcting it. All right, so this is the patient's outcome post-operatively. I'm not going to go into the spinal osteotomies because it's again going to take a long time, but basically the three types of spinal osteotomies we need to look at: the Smith-Peterson osteotomy, where you only do remove the posterior facets. the 3-column pedicle subtraction osteotomy, where the apex is in the anterior body, and the vertebral column resection, where you need to basically remove the entire vertebral body, which is reserved for severe deformities. So in early onset scoliosis, again, you just need to look at the various options, which is observation, role of casting, which is, I think, underutilized, growth rods, and early fusion. So this is a child who basically is just 2 years old, and obviously you can't operate on this child. So the MRI is normal. So this child has been treated with just a cast, and will continue to be treated with a cast for a couple of years, after which we'll try to brace and then think of surgery at a later point in time. I'm going to end with this picture. So this is a patient who actually had a sprangled shoulder and presented with the scoliosis, and you'd kind of think that this curve is significant. The MRI was done, it shows a T3rd cord and a diplomylia, and the patient actually underwent a neurosurgical procedure for the detethering, and at the same time we got a cast impression. The patient has then been treated in a brace, and this is what she looks like clinically right now. So the sprangle and the interspinal anomaly can sometimes confuse the picture. So it's important to look at the history in the clinical evaluation, look at the etiology, the radiology, the progression, look at the treatment options, and of course follow up all patients, because that's really the most sobering. And I'd like to thank you